morning, everyone. As Denise has kindly introduced me, I'm Michael, and to my left is Marion. What we're going to do for the next few minutes is just strip back all the amazing talk about use of apps, use of technology, how it's the way forward, what's going on, and believe me, I'm a great believer and I use all of that. But what we thought would be quite interesting to talk about actually what's happening on the ground, particularly in the NHS, and my own experiences at Oxford. Just very briefly, my own digital journey started in Radlett, which is where I live. It then took me to UCH, a big hospital in London. It then took me to Mount Sinai Hospital, and finally to Oxford. When I arrived at Oxford, it was as a result of having had Crohn's disease since the age of 12, which is an incurable bowel disease. After a number of operations and intestinal failure, I became the 11th person to undergo a bowel transplant at the Churchill Hospital in Oxford, in the UK. I was the strange patient that walked in with a blog that they weren't quite sure what to do because I was slightly informed. So everybody kept giving us the term e-patient, and I was a little bit, e-patient, what does that mean? And it's that stuck with me because they say, oh, well, e-patient, you're engaged, you're empowered, you're educated. I don't think my teachers think I'm educated, but the point being, in my belief, every patient is empowered, engaged, and educated. It's just whether they choose to use that information. So I refer to the term as that I'm an interactive patient, that I'm an I-patient. And today's discussion, we're going to talk about that interaction at the NHS at Oxford and how I work with Marion. So I've talked enough about myself. Marion O'Connor, I have to say, it's an unbelievable privilege to sit with her on stage after this journey because she is one of two people that literally saved my life and changed my life. She's lead dietitian of intestinal transplant at Oxford. She has expertise in intestinal failure and intravenous feeding, and the majority of time she's spent with patients with long-term chronic conditions. But I'll just hand you over to Marion just to talk a little bit more about what you do.
Yeah, as Michael said, I worked mainly with, I've been about 10 years in Oxford, and I've worked with gastrointestinal problems like chronic illness, like Michael said, Crohn's disease, irritable bowel syndrome, another complaint called dysmotility. So my experience is, as I said, with long-term kind of chronic illnesses. And I think based on this, my belief is that you need to listen to the patient to be able to get anywhere to be able to help them. As part of my background in intestinal failure, obviously we have patients who go home on intravenous feeding. Now this, it has to be set up properly because the risk of going home with a central line in place can be life-threatening. So we have to communicate with these patients very rarely. And I'll talk about communication because I think communication is something that maybe we haven't spoken about today, but from a hospital perspective, and I'm sure lots of people who are patients here will agree with me that this is where there's a major downfall in communication sometimes. Basically from getting communication, but maybe getting different bits of communication from different people that don't really add up sometimes. So how we overcame this with our intestinal failure nutrition team was to actually email. So we email patients regularly. It's been very effective because obviously we have 30 home patients around the country. We could not take calls all day long. We have our own jobs to do within the acute setting as well, and then to be taking calls, which was the only way to access me as a dietitian or the pharmacist or the nurse or the doctor that was on our team. So we've used email for quite a while, and I think it's quite effective.
When I came to Oxford just over 2 years ago, I'd been in 5 different NHS trusts over 30 years, and it was the first time a doctor actually emailed me. It was quite a bizarre experience for someone to say, here's the email address, send me your information. Right now, just to give you an idea of how we communicate by email, text, we use video, we share information on social media, and for example, if I've got an issue with a wound or a problem, I'll take a picture on my phone and send it. The surgeon will look at it. He'll be able to give me some advice, come straight back to me, and it immediately saves me the stress and worry of what the problem is. He's in theatre most of the time. He can answer the questions, and within 5 minutes, we've solved a problem that otherwise would take a 2-hour journey for me to get to hospital, him clinical time, and it's solved that way. Now, when I arrived on the ward, I came with this blog. How did it feel to you suddenly dealing with patients that were a little bit more interactive than others before?
My introduction to the blog was when Michael came and had his transplant. And a transplant is a huge, major surgery. It's about 23, often up to 23 hours of surgery. And afterwards, obviously, lots of problems arise within the first few weeks. So you're dealing with these problems. And obviously, Michael was the patient on ITU, and he had his lovely wife, Justine, there beside him. And I was doing, changing the intravenous feeding, and discussing things with them, as I do with the patients and their relatives. And then I would go back to the ward and meet the transplant coordinator, and she'd say, "Oh, well, you've done this today." And I'd say, "Well, how did you know that? You weren't even there." And then this word blog, and I must admit I knew nothing about a blog. I mean, I've heard of blogs, but it was something for maybe younger people or somebody, my younger sister, brothers. But for me, so then I eventually worked up the courage to have a look at the blog. And that's where it started. But I asked myself, I suppose, and people have asked me, "Oh, how do you feel with having a blog, somebody having a blog?" But for me, to be honest, it doesn't make any difference, because as a professional person, I should be, what I'm saying should be exactly what I would say, and should be the correct information that I'm giving to the patient, whether it's on a blog or whether it's what I'm saying right in front of them. So actually, from my perspective, it didn't bother me. I promote patients being informed and
I was going to
engaged.
say, and at Oxford it's quite unique. You get a lot of patients coming in with long-term conditions who are informed. How does that impact on how you treat them, how you engage with them?
I think from my experience, this is why I discussed my experience in the beginning, is that's quite common within our intravenously fed patients at home, that we encourage them to be informed, because then they can take more control when they come into hospital. For a good example is, care of that line is really important. It's life-threatening if they get an infection. They come in through A&E, and the first doctor they see will just say, "Oh, fine, we've got access, we'll put something through that line." Well, that could be detrimental for that patient. So we train them to actually be able to say, "No, hang on, you cannot use your line." So simple things. It seems like a simple thing, but they take control of their care as much as possible.
And how do some colleagues feel about it? Because there's a big factor. As a patient, and you sit in the NHS, and I had this with the Transplant Foundation at Oxford. We wanted them to set up a Facebook page, and for 3 months, the chairman was saying to me, "Nobody goes on Facebook. Nobody uses Facebook. Everybody likes silence." And eventually you overcome that. How do your colleagues feel often about social media at the moment and use?
I think there's probably reluctance to use it for lots of reasons, and I think we have to understand the whole health professionals, and I think probably one of the reasons that people need to understand is that from the point you get your professional qualification, whether it be a physiotherapist, a pharmacist, a dietitian, a doctor, you are told that you do anything outside of work or inside of work, you have the potential to lose that. So I think you always live with that, and this is your livelihood. This is what you've worked towards. So I think that that will change as it changes with having proper guidance and people usually having common sense of what you put on there.
Yeah, I was going to say, I find the big thing, whatever I write on social media, unless I'm having a go at my football team for losing, which is quite often, is very honest and very open about my treatment. I'm very happy to say the good and the bad about how I'm feeling, what the treatment I'm getting. So as a patient, I think if you're open and honest, you get far better feedback from the doctors. And
yes, and I think that's why we use your blog. And just to say that we use Michael's blog for new patients. So we obviously get, now that Michael's blog is out there, and the other patients are also involved in social media, but probably not to the extent of Michael's at the moment, but we do encourage them to do it. We use anybody that comes through to us from any country. We have queries now from Europe and all over the world. We actually refer them to Michael's blog. And the reason we do that, and I think as health professionals, we can give one aspect of the care of the patient, which is often very scientific. I can tell you exactly, or Mr. Vadia can tell you exactly how the surgery will work, what immunosuppression, what will happen. But what we can't tell you is how you're actually going to cope after you have transplant. And I think really, I feel, and I think we feel, this is why we've taken on social media, is that's a very important part of the patient's care. It allows them to be more compliant with their medications, which is extremely important. They come to us knowing that we're actually going to listen to them. because maybe we've read the blog and understand that, okay, we've done this today to Michael because we have to do it because he has to take it, but Michael's not happy. But then we have to accept that Michael's not happy, but we know we're doing the best for Michael, and that's what's important.
And, you know, we've experienced the other side of the coin where patients will be sitting on wards, go onto Facebook, have a rant or write a blog post about how badly they perceive they've been treated. What effect does that have for you? I mean, because as a fellow patient, we can respond to another patient, and we do, trying to calm it down, but there is a lot of emotion attached to being a patient as well, and how do you respond?
I think from obviously working on the wards with all the other health professionals on the ward, we all do every single day, and I don't think there's any health professional would say that they don't do their best every day. And I think once you know you do that, there'll always be people who will have a perception of what you've done, and it may be wrong, that they will see it's wrong and they may be unhappy with. But I think you just have to accept that that's the way they feel, and you can then address that the next time you see them by explaining, because sometimes it again goes back to communication. Have I, as a health professional, explained exactly why I've done it? You know, is there some way we can help? Because sometimes it's maybe a psychological aspect which we're not very good at dealing with. Can we get, now that we're aware that this is a problem that we didn't have time to unravel in our 10 minutes or 15, 20 minutes of seeing the patient, we can then, by the time they come back the next time, think, well, would you like to see a psychologist or a pain specialist or something? So we wouldn't use it wouldn't see it as a negative thing. I think that's just the way the patient feels, and we have to acknowledge that.
And, you know, we spend a lot of time exchanging articles, we exchange videos, we use LinkedIn quite a bit to collaborate on things. So there was an example recently that I'd never heard of it, but magnesium levels had dropped. You wanted me to try this transdermal magnesium spray, but the first comment was, will you go out to your patient groups and find out what the side effects were if other people have used it before we come back? And I had another situation with a surgeon the other day where he wanted to try a new drug, and he's like, can you go out and talk to people, see how they've responded at this dosage?
And I think this goes back, obviously, to the previous talk where someone said, well, ask the patients. And I think nutrition is, as we've seen in another talk, one of the probably most topical topics on the internet, and becomes very difficult, even as a nutritionist or a dietitian for many years, to actually be able sometimes to discern between what's actually correct and what's maybe slightly incorrect. And obviously we're dealing with vulnerable people, so it's our job to give the correct information. There is always products. We have to be open-minded, and I think that's where sometimes people need to be more open-minded. That just because if it's not in a medical paper or whatever, it doesn't mean that that problem doesn't exist. It has to start. My belief is it has to start somewhere. And if people have been helped by, for example, transdermal magnesium or probiotics or whatever we usually ask about, then that's what we've got. As long as it's not going to cause the person any harm and it's safe. And this is what we have to be sure, that when we use any form of social media, that we protect the patient's identity, it's confidential, it's safe. And I said that goes back again to being professional.
I was going to say, there's a lot of engagement on social media, a lot of people talking. You know, I do it an awful lot of the time, as do plenty of others. How do you decide what's a trusted source? How do you decide which patients you're going to defer to give information out to other patients?
I think we'd have certain, when people talked about diabetes, we would use like Diabetes UK or really kind of ones that we would professional. And how do
you get to know which patients are giving good information? I mean, you're very kind, you say my blog goes
out,
but
I think the only experience I have, I suppose, is basically with yours. So, and because it's an accurate, even at the point when your wife was doing it, it was extremely accurate. And I was thinking, first of all, I thought, how could they actually retain all that information? Because it's quite a lot of complex information, and it was very accurately portrayed. I think it's difficult to discern, because even as I said, as a dietitian for many years, when I get on there, I'm almost convinced that something's going to work, when actually physiologically it can't, which is sometimes the case. So it's difficult.
And I've got a couple of questions as we get closer to the end of the session. What practical changes do you think social media and use of technology, even whether it be email and text, has made to the clinic at Oxford and to specifically, I guess, intestinal transplant? Because for me, it's opened up a whole world. Every patient that goes through Oxford on a transplant, we're now connected. We talk, we share ideas. If I have an issue, I tend to go to the patient first in a way to say, well, have you had that side effect or have you had that problem? So you build a community. How as a doctor, as a medic, do you see the benefit at Oxford?
I think the benefit is that patients, I think first of all that we have the patients that come to us, that because we have acknowledged that we can't address the issues afterwards, as in things like how do you cope afterwards being well. I mean, you've been chronically ill, on intravenous feeding for some of our patients have been on for many, many years. And it sounds really strange, but after you have a transplant, you would automatically say, great, I've got my life back. Well, actually, that's not the case. It's you then have to cope with being well and building a life again. And we can't do that. We can, and when people go through problems like Michael went through and the other patients, I can sit there and think, this will be okay, but I can't say that because they have to go through that. And it helps them to do that because then they can relate to other people who've had the same problems. Time efficiency is a very efficient way of using time, and I think I think in this kind of illnesses, there's a lot of specialities in hospital where it probably isn't necessary because it's acute and you go in, you have your surgery, and then you go out again. But in certain areas, in long-term conditions, patients have a way, I suppose, of getting their problems out because there's lots of frustration. So that from the time perspective, we can then spend the time getting if we think there's a problem. Rather, we can, before I see you in clinic, for example, if Michael sends me his details of his, outputs and his inputs and his pain and whatever it is, I can then look at those. We can discuss it as a team, which we meet every day and every week as a bigger team. Then we can discuss it and have the solution by the time Michael comes, rather than him having to come down and then sit on the ward for 3 or 4 days, and then. Yeah,
I mean, for me, it's that constant communication and that build-up of trust. As a result of the transplant, I ended up with some skin cancer, and the sun would come out in London, which is very, very rare, but when it does, my surgeon would text me and go, right, remember the temperature is X today, don't forget you need your sun cream on, and don't forget your hat. Now, okay, that's number one, because he's an extraordinary person, as of course you are, but number two, you get that immediate relationship, and technology gives you that. I want to just wrap up, if you like, with a thought about what the future might hold for Oxford. Just on the Eurostar yesterday, Anil Vaidya, surgeon, texted me and confirmed that next week, 13th of June, we are going to do a live tweeting of a kidney transplant from the OR. So I'm really excited to be in the operating theatre and awake for a change. But yeah, no, it's really groundbreaking for Oxford to take on this. So we'll send out some more details, but on practical terms, what do you think the future might hold? How will patients benefit? How do you guys benefit more from this interaction, this technology? We sat here at the last talk planning out apps that we were going to do.
I think we've experienced how it has actually changed, because we have intestinal transplant, as Michael said, is quite rare. There's 2 centres in the UK, Cambridge and Oxford, and we started doing intestinal transplant about 5 years ago, almost 5 years ago now. And obviously there are lots of patients who it's not appropriate for, but what we need to do is get out there and get patients who can actually make that choice, and we have to get through the physicians and the people looking after them. So it's a way. What has happened with a few patients is they've actually, Michael did an article in the Daily Mail, and a friend of a patient who actually knew the quality of life that patient had was very, 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 very poor, and he brought that article to the patient, and then that patient contacted Michael, who then contacted us. The patient came and then was subsequently transplanted, and life is very different for him now. So it's not a promotion. I'm not promoting. It's not the transplant bit I'm trying to promote. It's the informed, that the patient became more informed, because they were, there wasn't. Things have to change. Things will always change very slowly in the health service, and if you're not given that choice from the beginning to actually give you the option to even think about something else that's there, then it's not very fair.
I think the best journey for me in social media, and Denise put up a brilliant tweet about curing somebody in New York. 4 patients have now gone to Oxford, either going through or have had bowel transplant as a direct result of the blog or social media or media activity we've been able to generate. And that really is the power of social media. And you know, for me, it's a great privilege because I'm reliant on a person that will genuinely interact. The system doesn't interact. You're relying on the individual to interact with you. And I finished on time, Denise.
Yes, you have, and I know that you have generated interest in